I've been asked to talk about surgical salvage for the primary disease, which could be a very long discussion, and so I've decided to focus on an area at the request of the two chairmen on robotic surgery. My disclosures are that I do instruct for Intuitive for robotic surgery. I'm a consultant for Luminis and on the advisory panel for Med Robotics, but I receive no speaking honoraria from any company. The patient who comes to my office with recurrent head and neck squamous cell carcinoma is the most difficult patient. And it's not only because of the operation will be a difficult operation, it's because more of the discussion I'm going to have with the patient. We have a lot of presentations today that include science, but this discussion in the surgeon's office is mostly an art discussion. I think the doctors here would agree. Because not only are we discussing with them issues related to morbidity of the treatment, the impact of their quality of life, and the impact on their survival, they'll hear all of the things that we talk to them about, and then they still may have a strong feeling that regardless of my chances, I want you to go ahead and proceed. And it's the struggle that we don't understand because it's not a cancer that we have ourselves. And I've had a health issue before, a sports injury, and I chose to do what my surgeon told me not to do. So even as a physician myself, I didn't follow the recommendation based on science, on numbers. I made a different choice. It was a very personal choice. And the patient who comes in the office with recurrent disease is having the same challenge. They're going to hear that their survivals are unlikely to be anything that's significant. They're going to be such dismal numbers, and they don't even want to hear that stuff, but they just want to hear that we're going to help them. Trigger?
No, it's...
Okay. So what has improved is what we can offer them for surgery. Microvascular reconstruction has really brought a tool that we can use to improve some quality of life issues. With large resections, we can bring fresh tissue into that site, which then even makes them a reasonable candidate for reirradiation if necessary. Also, transoral laser microsurgery for any site, oral pharynx, larynx, is available, and that's a minimally invasive operation. And transoral robotic surgery is really an extension of transoral laser microsurgery, where, again, it's a minimally invasive operation, and then the outcomes for the patient can be different. This is a summary of what was presented earlier, but in discussing with the patient, there are going to be things that are in their favor or not in their favor. They may have poor performance status because of their previous treatment. Significant weight loss with the chemoradiation, significant problems with dysphagia following treatment. Along with the weight loss, then they'll have fatigue issues, even hypothyroidism that they have to manage. Advanced stage 3 and 4, I generally quote around a 30 or 20% survival for each of those two stages. If the patient had a short disease-free interval, it's a poor outcome factor for them. If they recur in the oropharynx, and we think it's because a recurrence in the larynx, which is a good factor, a favorable factor, the lymphatic drainage is different, say, than with the oral cavity or oropharynx. Maybe also in the oropharynx or the hypopharynx especially, the recurrences aren't caught as quickly as, for example, the oral cavity or even the larynx. A recurrence around the vocal cords is going to produce a symptom that is easily noticed by the patient, where some of these others may not be so easily noticed. And then previous chemotherapy. It seems that chemotherapy, if the patient had received chemotherapy, maybe that has selected out a genotype of the cancer, for example, that is more resistant or more aggressive than the others. So I had the opportunity today to consider which site I wanted to talk about. We could talk about oral cavity salvage surgery, oral pharynx salvage surgery, larynx salvage surgery. And I think that wasn't the intention today. I think instead I'm going to choose just to discuss oropharynx. And I'm just going to highlight this one study that came out of 4 institutions: University of Alabama, Birmingham, Mayo Clinic, Rochester, MD Anderson Cancer Center, and Henry Ford Hospital. And this is a study that I put together where we compared equally matched patients who underwent TORS, 64 in each group, versus open salvage surgery. These patients were T1, T2 tumors only. I did not want to compare a T4 salvage operation open with a T1 robotic case. Not fair to compare those two. So these are T1 and T2 tumors of the oropharynx, so base of tongue and tonsil. Will you advance, please? And comparing them, there are some significant differences between the two groups. In the dark bar, that's our TORS patient group, and then in the light bar, that's our open salvage group. In surgical time, we had 100 minutes approximately for the TORS versus 350 minutes for the open. And with blood loss, significantly higher amount of blood loss translating into transfusions in the open group compared to the TORS group. We may need to get a new battery for this. Advance. The other difference that we found is that hospital length of stay was significantly shorter in the TORS group. This has an impact not only on their recovery, but also has an impact on the economics within our healthcare system. Patients staying a week if they have an open operation versus patients who are going home in approximately 3 days. Big differences between tracheostomy and PEG tube use, and I'll highlight these in another way. But we saw a 23% use of tracheotomy in the TORS group versus 80% in the open group, and a 36% use of a PEG tube and 75% use in the open. When we look at the retention between these two groups, at 1 year, there were still over 50% of the patients in the open group who had a PEG and used the PEG to either primarily or assist their nutrition. Whereas in the open group, in the TORS group, only 5% of the patients still had a PEG at 1 year. Other postoperative outcomes, the infection rate we found lower. We're working in a closed space versus an open space where we have a possibility of a fistula, for example. It's going to increase our infection rate. Airway edema is very similar. Postoperative bleeds were similar. But the thing that was really surprising was that there was a difference between positive margins between the two groups. We tried to figure out why there was such a great difference between the two groups, and the thing that we came down to was, in a TORS operation, you can repeat the operation. So if you have a positive margin at your tonsil, for example, that patient can be brought back to the operating room within a week even for a repeated TORS operation. Where in an open salvage operation, the primary site is now covered by a free flap, likely, and it's not possible to go back into that wound to know exactly where that positive margin is located. So there's an advantage then for a TORS operation, and I would guess that this would be the same for any TLM as well for those surgeons who perform TLM. And I think that may be a reason why we saw an improved survival in our TORS group, 2-year recurrence-free survival versus the open group. So the open group followed what we had discussed earlier about the survival rates for oropharynx specifically, where in the open group we had a 33% disease-free survival at 2 years, but in the TORS group it was 74%. And it may relate to that margin difference. Of course, there were some issues regarding patient selection, that maybe the open group was different than the TORS group. But most of the open patients were performed before the availability of TORS. So it wasn't going to be necessarily a selection bias because they weren't all being treated at the same time. And this was our 2-year overall survival with 43% in the open group and 74% in the TORS group. So salvage for TORS is a very effective way to treat a patient, especially in that site where we tend to see a lower survival rate, the oropharynx, compared to the larynx. The favorable patient is going to be someone who has good performance status, a small primary, located in the oropharyngeal site because TORS is ideal for the oropharynx, and a disease-free interval more than 12 months. Thank you. I'll take questions now, as we did for the last.
I'm Dr. Tukran from India. My question is, when you have a surgery for salvage of the primary, how do you address the neck at that time? Does operating the patient with TORS or open affect your decision?
The question I'll repeat because the microphone wasn't on at the beginning is, how do we address the neck if we're operating on the primary with TORS? If the patient is N0, we address the neck just as Dr. Levertu just reported. We use a PET scan that's a PET CT at approximately 3 months following their primary treatment. So if they're N0, we observe the neck. We only treat the primary in that case. In my institution, the way I manage the neck and the TORS, I don't do them at the same time. I separate those two operations at least by 1 week. Philosophically, I perform the neck dissection first because that gives me the opportunity to ligate the lingual artery, for example, if it's a base of tongue recurrence, which is very important because a catastrophic bleed following a TORS operation is just unacceptable. So I perform the ligation of the lingual artery prior to the TORS operation.
What I wanted to know was, when you are doing a primary surgery for primary recurrence in an N0 neck, proved on PET CT, when you do raise a cheek flap or do a mandibulotomy or whatever, do you do at least a supraomoid or you don't do anything in the neck?
For a TORS operation, I do nothing for the neck. For an open operation, I do the neck because the reconstructive surgeon needs the vessels.
Possible HPV connection with those patients are likely to be smokers or non-smokers. The reason I ask that is because in the HPV patient population, the oropharynx, even the recurrent disease patients actually do have a better prognosis and they live longer based on recent data. So I'm wondering whether you're selecting patients who have a better prognosis by being HPV positive.
That's a very good question. That was actually one of the criticisms brought up with that paper by one of the reviewers. We did not have HPV. It wasn't you, okay. We did not have HPV data on these patients. We had some HPV data, but it was different by institution. And so we were unable to evaluate that, but it is a very good point that the selection could be different with HPV.
But I guess it's still very good survival, even if they are HPV positive recurrences. It's pretty good survival. It's 80%, you know, so. Last question, please, up there.
In the back,
Yeah.
yes.
2 questions. How many repeated TORS procedures were there for positive margins, as you said that it was easier to come back if there was a positive margin with TORS?
Yes.
And the second question is, did any of the patients included in your cohort have adjuvant therapy?
The first question, there were 64 patients in that group. I would have to look back to know exactly how many repeated operations there were, but there were, I want to say there were around less than 10, around 8, but I don't know exactly the answer to that question. The second question was, I forgot it already, sorry. Adjuvant therapy. None of them received adjuvant therapy. They were, well, you know what, that's a good question. None of the robotic patients received adjuvant therapy, I'll say. The open, they may have received postoperative reirradiation based on some of their pathology characteristics, and now that they had fresh tissue in the area.